welcome back. Let's look at gestational diabetes. As I mentioned to you earlier, it is not actually diabetes. By definition, there is hyperglycemia, first time diagnosed during pregnancy, and usually returns to the normal glycemic status after few months of childbirth, a few months after the childbirth. Okay? So this is basically impaired glucose tolerance. It is called as gestational diabetes. Blood glucose level is higher than normal, but it is not at the level where you will call it frank diabetes. So this is basically impaired glucose tolerance. The importance of this is, I think I mentioned this earlier as well, these patients who have gestational diabetes, although after childbirth this will go back to normal, but you have to keep monitoring them. So they have increased chances of developing diabetes later in life, plus the babies who are born to these mothers also need screening. So they have increased chances of developing diabetes in their lifetime. Okay? This is the recommendation from International Association of Diabetes and Pregnancy Study Group. They say all non-diabetic pregnant mothers should be screened for GDM at 24 to 28 weeks of gestation. Now moving on to complications of diabetes. Now complications of diabetes are many. There are early complications which are mainly metabolic, and there are late complications. Now early complications are usually due to deranged blood glucose levels, hyperglycemia or hypoglycemia. Now hyperglycemia, there are two complications. First one is called diabetic ketoacidosis. Second one is called hyperosmolar hyperglycemic state or hyperosmolar non-ketotic coma. Now this one is associated with type 1, and this one is associated with type 2. Okay? Hypoglycemia can also occur in diabetic patients, and it is usually a complication of treatment. So if you overtreat the patient, hypoglycemia can result. Now looking at these two complications, the ketoacidosis and hyperosmolar non-ketotic coma, let's look at DKA first. When there is insulin deficiency in type 1 diabetes mellitus, there is lack of glucose entry into the cells, so there is increased lipid and fat metabolism for energy, leading to production of ketones. These ketones are acidic, so you will have these ketone production plus you will have acidosis. Thus the name ketoacidosis. Plus you will have large amounts of glucose in the blood. This hyperglycemia will lead to osmotic diuresis. So when glucose is going out with the urine, it will take a lot of water with it, and the effect of this one will be that the patient will get dehydrated. You're losing a lot of water from the kidney, so there will be ketoacidosis plus dehydration, two major hallmarks of DKA. Now common precipitants, what causes patients to develop DKA? The patients who have type 1 diabetes, if they develop an infection, myocardial infarction, any sort of trauma or injury, or if they miss insulin dose, they are prone to develop DKA. Now DKA, if you look here, when there is insulin deficiency, all right, increased lipolysis, you have increased fatty acids, increased ketones, leading to acidosis. Now these people will also have vomiting. At the same time, when you have increased glucose in the blood, you have increased glucose appearing in the urine, you have osmotic diuresis. So this diuresis together with vomiting will lead to dehydration. So at the end, these patients will have hypotension and shock if dehydration is very severe. All right. Now, as a response to this hypotension and shock, catecholamines, cortisol, growth hormones, and these will be released. All right. But rather than helping, these hormones can actually further aggravate these complications, thus it becomes a vicious cycle. So, it becomes more and more severe. Dehydration becomes more, acidosis becomes severe, so on and so forth. So, it is a medical emergency, DKA. All right. There will be dehydration, hyperventilation. This is usually compensatory respiratory effect because of acidosis. So, patients are trying to exhale out more carbon dioxide, hyperventilation. Okay, these ketones can be present in the breath, and these patients can have fruity smell. These ketones have fruity smell. The urine also will have a fruity smell. Abdominal pain, altered consciousness, and shock. And DKA has a very high mortality rate if it is not treated immediately and properly. Okay. So, if you look at the biochemical profile of a patient who is having DKA, blood glucose levels will be high. You will find ketones in the blood and also in the urine. If you do arterial blood gas, there will be metabolic acidosis, respiratory compensation may be present. If you do urea and electrolytes, there will be dehydration, electrolyte disturbances, there will be high anion gap because of accumulation of ketone bodies, and there could be even acute kidney injury. Okay. If you do full blood examination, you will find evidence of dehydration. You can also find evidence of infection if this was the cause that led to DKA, for example. If MI is present in the patient which led to DKA, then ECG will show changes of MI. So, all these investigations will be required in order to establish the diagnosis of DKA. Okay. Now, ketones, just a little bit about ketones. They are produced by liver through metabolism of fatty acids. They provide actually a ready energy source from stored lipids, but the problem is when they are produced in very large amounts, then they will lead to acidosis. Okay, so they will increase if there is carbohydrate deprivation, which is happening in type 1 diabetes, right? This can also happen in starvation. People who are starving for a long time, they can also have high levels, or people who are having very high fat diets can also have ketones in their blood. Okay? There are 3 ketone bodies: acetone, acetic acid, and beta hydroxybutyric acid. It can be measured in the blood, or they can be measured in the urine. These are the 3 ketone bodies. Now, they are used as diagnosis of ketoacidosis or screening for ketoacidosis in suspected patients. This is the reference range. Now, for ketones, you don't actually need an accurate measurement, because once you find ketones in a patient's urine or serum, you have to start the treatment. The levels of ketone is not important. So, a simple urine dipstick test is even sufficient to diagnose patients with ketoacidosis. Okay? The other complication, hyperosmolar non-ketotic coma. I don't know why coma is with K in the abbreviation. It should be HONC. All right? Okay. Increased osmolality is common in elderly patients with type 2 diabetes. There is excessive amount of glucose in the blood. There is peripheral resistance to insulin, but the amount of insulin which is present in the blood prevents ketosis. So, the small amount of insulin which is there is enough to prevent ketosis, but hyperglycemia in these patients is very high and osmotic diuresis will be there. So, you have hyperglycemia, osmotic diuresis and dehydration without the formation of ketone bodies. Again, severe illness, dehydration, glucocorticoids, diuretics, parenteral nutrition, dialysis, surgery, all these can precipitate this complication in elderly people with type 2 diabetes. If you compare to diabetic ketoacidosis, what are the similarities? Patient will have dehydration. There will be some hyperventilation. There will be disturbed conscious state. Patient can even be unconscious, can lead to shock. The differences between the two, that you will not have ketotic breath in these patients or abdominal pain. But in these patients, they usually present with mental disturbances and headache, and there is increased risk of thromboembolism. Extremely high mortality. It is actually higher than DKA if these patients are not treated. If you look at blood glucose levels, they are extremely elevated. They can go even up to more than 50 millimoles per liter. Serum osmolality is increased. There is evidence of dehydration. Acute kidney injury may be present. Again, on full blood examination, you may find evidence of dehydration and infection if it is there. There is usually no acidosis or very, very mild, because ketone bodies are not produced in these patients, and you will not be able to detect ketone bodies in the blood or urine. Okay? Now, there are also long-term complications of diabetes. There is microangiopathy. There is progressive narrowing of the small blood vessels. Progressive narrowing of the small blood vessels, and this affects mainly three areas: eyes, kidneys, and peripheral nerves. Retinopathy, nephropathy, and peripheral neuropathy. Retinopathy is that the capillaries which supply the retina, there is macular edema, neovascularization can lead to blindness ultimately. Nephropathy is when you have thickening of glomerular basement membrane, which will reduce GFR and lead to respiratory failure. And the blood vessels supplying the nerves will also be affected. There will be ischemia of the nerves, damage to myelin sheath, and there will be impaired nerve function or even cell death. And once nerve cells die, they cannot regenerate. So you have retinopathy, nephropathy, and peripheral neuropathy, but these complications take decades to develop. Okay, so it may take 10, 20, or 30 years before these complications develop in a patient with diabetes. All right. So how these complications develop? The most accepted theories are that the chronically elevated sugar levels will glycosylate proteins in the vessel walls. The vessel walls become leaky. There is compensatory increased production of proteins in the wall, which will lead to progressive narrowing of these micro blood vessels. There is also production of reactive oxygen species, and there will be local damage, and as a reaction there will be fibrosis and then narrowing of the blood vessels. Okay. Another laboratory test which can be used in diabetes is measuring albumin in the urine, albuminuria. In the past it was called microalbuminuria, but now it is called albuminuria. So it is an early sign of nephropathy. If kidney is being damaged, albuminuria will be present. So it's an early sign of nephropathy. Okay. Retinopathy, if you look at the retina using an ophthalmoscope, so you can see these exudates, these patches here. So this is a typical retina which has retinopathy due to long-standing diabetes. Okay, there are many changes actually. No need to go into details of those. Under long-term complications, there is also macrovascular complications. In these patients, the atherosclerosis is accelerated, increased risk of ischemic heart disease, stroke, transient ischemic attacks, also peripheral vascular disease. There are some other complications in diabetes like immune dysfunction, impaired wound healing, and sexual dysfunction. And this is one of the common complications of long-term diabetes. I think you all must have heard of this, diabetic foot ulcer, because there is, now the reason for this, there are many. Number one, you have peripheral neuropathy. Okay. Number two, you have impaired wound healing. So these patients will not feel the pain when there is an injury because of peripheral nerve damage. They will not feel the pain, and because of poor wound healing and you don't have good blood supply, you will have these wounds developing in the feet. And if you remember earlier when I showed you the diabetic statistics in Australia, there was a large number of amputations. So if these wounds are not taken care of, they can lead to necrosis of large areas of the feet and the lower limbs, and sometimes amputation is required. And sometimes it is said for diabetic patients, they should take care of their feet more than they take care of their faces. Okay. Now the last topic, which is hypoglycemia. You have decreased plasma glucose levels. It can be transient and insignificant, or it can be life-threatening. Life-threatening because, as I told you earlier, brain uses glucose exclusively. So if there is hypoglycemia and severe hypoglycemia, the brain will not be able to survive. It can occur in healthy appearing, so hypoglycemia can occur suddenly. Can also occur in sick patients due to a reaction to medication or of illness. If glucose level goes below 2.2 millimoles per liter, hypoglycemia becomes symptomatic. So to diagnose hypoglycemia, there are three, this Whipple's triad. So symptoms consistent with hypoglycemia, laboratory confirmation of hypoglycemia, and once you give the patient glucose, the symptoms are relieved. So this is Whipple's triad for hypoglycemia. Symptoms, initially there will be increased hunger, then there will be sweating, nausea, vomiting, dizziness, nervousness, leading to blurred vision, mental confusion, and if it goes below 1 millimoles per liter, can lead to coma and ultimately death. Okay. So the diabetic patients, especially type 1 who are on insulin, they must be educated on identifying hypoglycemia early. For example, if they skipped their meal or they didn't take proper meal but they took proper dose of insulin, they can go into hypoglycemia very easily. So they should be able to identify early signs and to consume some sugar immediately to prevent developing severe hypoglycemia. Okay, these are some of the causes of hypoglycemia. So fasting hypoglycemia versus reactive hypoglycemia. In this one, there is it can happen if there is insulin secreting tumors, for example, in the pancreas, too much insulin. Malignancy, so certain tumors can produce insulin like hormones. Hepatic and renal disease, when there is impaired gluconeogenesis. So these patients, when they are fasting, blood glucose level can go down very quickly. Once their glycogen stores are depleted, they can have sudden hypoglycemia. Addison's disease, because glucocorticoids are not there, as if you remember in the list of hormones, the hormones that increase blood glucose level, glucocorticoids were listed there. Epinephrine, glucocorticoids, ACTH, growth hormone, right? So in the fasting state, they maintain blood glucose. If somebody is having Addison's disease, during fasting state, they cannot maintain their blood glucose level, so it will drop. Sepsis can also lead to this. Reactive hypoglycemia could be due to if somebody takes a lot of insulin, exogenous or endogenous. Some drugs can induce, alcohol can induce hypoglycemia. Dumping syndrome. Anyone knows what is dumping syndrome? Very interesting. If you take a sugary drink on empty stomach, this could happen. Immediately it will get absorbed, and then the beta cells in the pancreas will secrete insulin, right? Insulin will be secreted. This glucose is immediately gone into the cells. Okay, insulin is still there. All the glucose is gone. So you can have hypoglycemia. That's why when you take a meal, you are having gradual absorption of glucose in the blood, and insulin is then gradually moving it into the cells. So if you have this kind of situation where you take a sugary drink on empty stomach, you can have this dumping syndrome. So it can lead to hypoglycemia. So if you feel dizzy after drinking Coke on empty stomach, this is the reason. Okay? All right, so what we covered today, let us summarize. For pre-diabetes and diabetes, what tests will you do? Now help me here, please. Which tests will you do to diagnose pre-diabetes and diabetes? Oral glucose tolerance. Yeah. Anything else? Fasting glucose level. Okay. Anything else? HbA1c. So these three. You can do blood glucose level. You can do oral glucose tolerance test. You can measure HbA1c. Okay. These three tests are available as well, but they are not routinely done. Okay, they are not routinely done. All right. For hypoglycemia, only one test, blood glucose level. Okay. For complications, for nephropathy, which test can pick up diabetic nephropathy early? Come on, just discussed a few slides ago. Albumin in the urine, right? So albumin urea. Okay. DKA and the hyperosmolar non-ketotic coma. For DKA, you have blood glucose, urea and electrolytes, ketones, and ABGs. For HONC, blood glucose and urea electrolytes. So usually ABGs are not required, but you can do ABGs for this as well. But ketones will be negative. Right? Okay, makes sense? So this is a case study. I think I will leave it and we will discuss it on Friday. And I will post a few more case studies. And please read them before coming for the session so we can have some discussion. All right, thank you very much. Anything else?